Hi, everybody. Today we're going to be working on labor and birth. So this is arguably one of my favorite topics. So I hope you guys enjoy it. So when we think about labor and we think about birth, we're going to first start thinking about factors that affect how our baby fits through the pelvis and things like that. So we're thinking about babies, we're thinking about pelvises. So that brings us to our 5 Ps. So our 5 Ps are all things that are going to be factors that affect, right? And so we have our passenger, and our passenger is our baby. And so if we look a little bit closer at our passenger, we're looking at not just the baby himself, but really like what kind of position the baby's in. Okay, so when we think about this, we're thinking about attitude, presentation, and position. I actually am going to change this so that I can zoom. All right, so this is our station. And our station has to do with where our baby's head is or presenting part is in relation to the pelvis. And so these little notches here are the ischial spines of the pelvis. And we call this 0 station when the baby's head, the bones of the baby's head are engaged in this spot. If the baby's higher than that inside mom, those are minuses. If it's pluses, then the baby's closer to coming out of the birth canal. Okay. So we hear station when we say like mom is 380 and -2. -2 is the station. Okay. One thing that's really important is how is our baby in position in relation to the pelvis. And so we determine this, this can be a little bit confusing. We determine it based on the occiput of the baby, which is the back of the head, in relation to mom's pelvis. So if this is mom's pelvis, her back side of her pelvis, where her spine is the posterior side of her pelvis. And then the anterior side is her front. For baby, we're looking at the occiput. So if we say the baby is occiput posterior, the back of the baby's head is towards the posterior of mom's pelvis. And so you can see in the picture then the baby's face is more towards the front. Okay. If the occiput is anterior, the occiput of the baby is towards mom's front and the face is facing towards the mom's back. This is the best position for the baby to come through the pelvis and to deliver vaginally because of a reason I'm going to show you in a minute. So then we can also have occiput transverse where the back of the baby's head is towards mom's right or left. Okay. And so this also does a little bit, instead of going directly occiput anterior and directly occiput posterior, usually our baby's a little bit one way or the other. So then you have right occiput posterior, left occiput posterior, and so on. Now, the thing that can affect if our baby is occiput posterior, that is especially a time that interferes with the flexion. So that is our attitude. So attitude, the definition is a relation of the different body parts like the head and the body in relation to itself. Okay, that seems a little bit confusing, but what we're looking for this is the baby flexed? So their chin is tucked down. And if they're flexed, then their head comes through the pelvis with the narrow part like this. Is the baby deflexed, where they didn't flex their chin down and then they come through the pelvis with the wider part of their head? Are they extended, where now their chin is up? So these are the different things related to attitude. If our baby is occiput anterior, our baby flexes well and comes through the pelvis with the narrow part of the head. If our baby is occiput posterior, oftentimes the baby is deflexed, and that's when it looks like this. Here's our occiput on mom's posterior, and you can see this chin is not tucked down. This baby's wide part of the head is coming through the pelvis this way. And so these labors tend to take longer and are a lot more difficult. All right. So whether or not we have a flexion or deflection is the attitude. All right. Presentation, what part is coming through? All right. So what we've just been talking about is the head. And so we call that a vertex presentation if the head is the presenting part. If we have the baby is breech, then it could be, we say it's a breech presentation. It could be a footling presentation if the baby's breech and the feet are coming down first. It could be a shoulder presentation if the baby is transverse. And then also, even if the baby's head is down, if they're extended in their attitude like this, we can have a face presentation. Okay, so these are all the things we're thinking about related to the baby, our passenger. All right, so that is the first P. The next P is our passageway. That's the pelvis, that's the vagina, that's the arch, the subpubic arch. And so this is how our passenger is coming through. All right. The other thing with our passenger is the placenta is included in that as well. For the next P is our power. So this is our contractions. This is our pushing effort. This is everything that is getting the baby down and out. Okay. And then the position of the mom. The position of the mom is going to affect the way the baby turns, the way the baby comes through the pelvis. A lot of stuff for those that have looked into this or have for their own births looked at things like spinning babies. We're looking at what positions we can put mom in to help get baby in that best position to come through the pelvis, especially occiput anterior. Okay. And then the psychologic response. How is mom coping? The psychologic response is it plays a big role in labor. If she's not coping well, her body is tense, it's tight, the muscles are holding things up, the lower uterine segment, or like the pelvic floor, everything is just snug and holding the baby and not giving space for the baby to come down. That can contribute also her cortisol and different things like that. So how's mom doing? The psychological responses are 5 Ps. So passenger, passageway, power, position, and psychological response. All right, so if you remember Leopold's from last week, Leopold's is a way that we can determine how the baby is laying. If we did Leopold's maneuvers, the nurse could determine that the fetus is in the ROP position. If the baby is ROP, where is the best place to auscultate the fetal heart tone? So let's go back and look at what ROP is. Here, right occiput posterior. So the baby's back, you can see, is on mom's right side. And the head is down. So by thinking about this, we know that we could Doppler on mom's right side, because that's where the back is, and that's the best place to hear the heartbeat. And we're going to do it below the belly button because the head is down. And so C is the best answer for this. Signs of labor. So some things that can show us that labor might be beginning. These are going to be things like we call it lightning when the baby drops down into the pelvis. Moms might notice that because they might feel more urgency to pee, but also they can feel like they can breathe better. Braxton Hicks contractions. So now the uterus is practicing, it's squeezing, it's contracting. Increase in vaginal mucus. They might lose their mucus plug now. So that's what we talked about. That's called the operculum, when the mucousy, bloody stuff that's been inside the cervix comes out. the cervix starts to get softer. So the cervix in a non-laboring woman is thick and it's firm and it's closed and it's holding that pregnancy in. And when we're getting close to labor, this starts to get soft and squishy. And so actually, if this doesn't soften, if I want to induce labor, I'll give prostaglandins to help make this soft and squishy. But for a patient that is going into labor spontaneously on her own, this is happening on its own. Sometimes you hear about women that have this surge of energy. They start nesting, they're cleaning the house, they're getting everything ready, and then bloody show. So bloody show happens because as the cervix is softening, the little capillaries in there can break. And so she might see a little bit of blood on her tissue. So it could be related to the mucus plug. It could be just softening of the cervix since there's a little bit of blood on her tissue. It's not like a period. That's bloody show. So when labor starts, it's because we are getting a shift in hormones. So remember, progesterone is maintaining the pregnancy. And as labor is starting, the progesterone drops way low, estrogen goes up. Mom's body starts releasing oxytocin, which helps the uterus to contract, and it's releasing its own prostaglandins, which is helping soften that cervix. We have different stages for labor. So in the first stage, this is when labor starts until we are fully dilated. So if anyone's not sure how fully dilated we're talking about, we call it 10 centimeters. And that's when there isn't any cervix left around the head at all, or the presenting part. Okay, so our first stage is from when labor starts until full dilation, when we are 10 centimeters. And we have phases of this. So the early phase is the latent phase. And in the latent phase, we are getting a lot of thinning of the cervix, which is called effacement. We get a little bit of dilation where it's opening, but a lot of thinning, softening. She's contracting, maybe irregularly. She's uncomfortable, maybe. Okay. And then when we hit the active phase of labor, things start to go faster. And so we used to call active 4 centimeters. Now we're saying active phase is more like 6 centimeters. And so from this point to delivery, the cervix is changing much more, much quicker. And so we're seeing dilation of 1 centimeter every hour or two, depending on how, if this is her first baby or if she's had babies before. Sometimes we can change several centimeters even in a matter of minutes. Just depends. Okay, this is the active phase of labor. Transition phase. Transition happens when the patient starts feeling the urge to push. And so transition is really transitioning between stage, or the first stage and the second stage. And so we have that last little bit of cervix that's going away. Okay. And so we're thinking about, usually this happens around 8 centimeters dilation. She starts feeling like she needs to push. Sometimes if she doesn't have like an epidural on board, especially, she might be involuntarily bearing down. And we want at this point to keep her in control and to help keep her from pushing against the cervix, because we don't want it to tear and bleed and swell. Okay, so that's transition. Now we transition into the second stage of labor. The second stage of labor, now we are completely dilated. And then we are going from we're completely dilated to delivery of the baby. Okay. And so this is second stage. This is when we're pushing. All right. So we can have active pushing that we can also, what we call laboring down, where we let the contractions move the baby down further into the pelvis to minimize the pushing effort. Okay. So second stage is to delivery of the baby. The third stage is going to be from the time the baby's born until the time we deliver the placenta. And this can take up to 30 minutes. And during this time, we have 2 nurses. One is managing baby, one is managing mom. And the one that's managing baby is doing the baby things we'll talk about later. the one that's mom's primary nurse, is helping the provider facilitate the delivery of the placenta. So this, even though we give 30 minutes for this to happen, this has to be managed well. We have a provider, whoever was delivering the baby, that's staying there and helping safely facilitate the delivery of the placenta, because the placenta is attached to the uterus, and then as it separates from the uterus, we need the entire placenta to come out together, and the membranes, everything together, so that we don't leave anything behind that interferes with the uterus's ability to contract. So once the placenta delivers, the uterus needs to contract and squeeze and tamponade the vessels, and this is going to minimize bleeding. All right. So third stage is the delivery of the placenta, and then the fourth stage is the first 2 hours after she delivers the baby. And so this is her body kind of recovering from the birth. There's a lot of things happening during this time. And so the other thing to just remember when we're thinking about labor is that in order to define labor, we're thinking about cervical change. Is the cervix dilating? Is it effacing? Because if we're not getting cervical change, those contractions are not labor contractions. Okay. All right. So second stage of labor, when does it begin and when does it end? So second stage begins with full dilation of the cervix, ends with delivery of the baby. So C, complete dilation and effacement of the cervix, ends with delivery of the baby, is correct. So we're going to just watch this video. This is a good example of what we're thinking about with thinning, or the effacement, and the dilation.
Hey, Charlotte. So I'm going to show you how we do the ping pong ball and balloon exercise. This was something that I got from a fantastic workshop, Stomp Out Boring Childbirth Classes. If you ever have a chance to attend that workshop, it's fantastic. So first part is we need to get the ping pong ball in the balloon. And if you just put it in, if you just try and open it a little bit and put the ball in, it's going to get stuck. And as I always said in class, stuck is a word we don't like to have associated with childbirth. So what you have to do is get your fingers all the way to the very bottom of the balloon and crank it way open, and then poke the ball in. And then you have that. And I would usually have the class do that, stuff their own balloon. It was always fun, and we'd have a good joke about it. And so then we've got that ping pong ball in there, and we're going to inflate it about halfway. About like that. And then you can let that ping pong ball settle into the neck of the balloon. Sometimes giving the neck a little tug really helps. And then you can let go of it and it'll stay inflated. And I show people how if you just squeeze the side of the balloon like this, not much is happening to the neck of the balloon here, and it's not opening very much. These are the Braxton Hicks contractions that are just practice contractions that are more and more common towards the end of pregnancy, but they don't do all that much to what's happening to the cervix. So real contractions happen at the top of the uterus. That's where the power of contractions happens. It's the muscle fibers at the top here getting shorter and thicker, which squeeze the top and then pull up on the side of the uterus here. And just like with real contractions, I have everybody just squeeze and then let go, and then just squeeze and let go. You just have to do a little bit at a time. And you can see how we're getting that effacement or thinning of the cervix down here. And not much dilation is happening while we're still working on shortening the cervix here. And this is a lot of the work that's going on in early labor. It's mostly about that shortening and less about the dilation. So once we get to much more effaced, much more thin, then we're going to start dilating the cervix there. And a lot of people get kind of nervous at this point. It's like, oh no, it's, you know, I don't want to push. So we always have a bit of a joke. It's just like actual labor, where you'd be like, it's okay, just breathe, do it gently. You're stretching beautifully. And then just give it one more push, and the baby will be here. There you go. And it's always just an absolute rioting class. Everybody laughs and has a blast with it. And I always tell class, take it to your young kids, and you know, if they already have kids, and this is a refresher class, show your older kids, because they think it's kind of funny. That's how babies come out.
All right. So that just gives us kind of a picture of what we're talking about with the thinning or the effacing and the dilation of the cervix, and Braxton Hicks contractions versus true contractions that change the cervix. Okay. So when we think about the cardinal movements of labor, this has to do with the way that the baby comes down and out. And things that can affect this is going to be the pelvis shape, and it can be the baby's head. So when we think about the pelvic shape, this is part of our P's, right? This is our passageway. And this pelvis, a gynecoid pelvis, is the best pelvis for a baby to come through. So the pelvis shape plays a role. And then everything we talked about with our passenger and the position and whether or not he's flexed and is he OP, and all of those things can affect this. Okay, so but the way that this looks is the baby engages, and then we have descent. We get flexion. The baby internally rotates. As the head comes out of the birth canal, the baby's head extends, and then we get an external rotation and birth by expulsion. So that looks a little bit like this. So here we see the cervical dilation, the head is engaged, and we're coming down. The head is flexed. And then we're going to get an internal rotation there. Extension as the head delivers. External rotation. And birth by expulsion. So those are our cardinal movements. One thing that just be mindful of is if we're watching how this plays out, and this is just going to play again, as we watch this happen, you can see on the external rotation how the baby's shoulder is underneath the pubic bone. If it happens that as the baby externally rotates, the shoulder catches onto the pubic bone, that creates a shoulder dystocia where now our baby is stuck. And that's an emergency that we'll look at later. So here's this external rotation. If the shoulder's up here caught on this bone, then we have a problem. Okay, so that's our cardinal movements. And what's happening with the baby during this time in labor is we have changes happening in the fetal circulation. And the reason for this is going to be primarily because that labor affects the blood flow to the placenta. So different positions that mom is in can affect the blood flow to the placenta. Her contractions affect the blood flow to the placenta because every time the uterus contracts, it's squeezing the vessels that are feeding the placenta. And so the contractions, if they're too close together, they're lasting too long. That affects our baby's oxygenation. Mom's blood pressure. So we talked about that in class before, how blood pressure affects the way we perfuse the placenta. And then umbilical cord blood flow. So if there's pressure on the umbilical cord, it affects the way that the blood's flowing through there. So we remember that the umbilical cord has Wharton's jelly in it that helps protect those vessels, but it's not going to completely keep everything from affecting it. And so pressure on the cord can affect that as well. For fetal respiration, remember that the lungs are our source of are not our source of oxygenation in utero. And so the baby's getting their oxygen from the placenta, but the baby's body is getting ready for that gas exchange to happen. And so amniotic fluid has been in those alveoli. And now the baby's body is releasing catecholamines, telling the fluid to get out, because we can't get gas exchange if we've got fluid in there. So it's kicking the fluid out. And then also as the baby comes through the birth canal, we get a nice good squeeze on the chest, which helps clear out fluid from the lungs so that when the baby takes that first big breath in, we can get gas exchange in the lungs. Okay, I'm going the wrong way. So what's happening with mom? In labor, everything is working hard. Her heart rate goes up, her cardiac output goes up. Now her blood pressure might go up because pain, anxiety, all those things. Respirations are going up. One thing that's not going up is gastric motility. And so for people that have been told when they've had their babies they can't eat food while they're in labor, or you've heard about this, that's often true, that we limit it to clears only, because that if she ends up with a cesarean, I don't want her to aspirate, right? And she's not digesting food well. Also, much bigger chance of vomiting. Okay. So, excuse me, when we think about maternal comfort, there's a lot of things that affect this. If you think about how the perception would be for different types of situations, maybe you have a patient who has had natural labor and delivery before, she's got a good support system, she's planning a natural birth again. Her perception of her labor is going to be different than maybe a teen mom who just found out she was pregnant last week, whose family is not supportive, things like that. So there's so many things. There's age, culture, background, history, all sorts of things that affect the way that you perceive your labor. So gate control theory is one way that we can, it's a non-pharmacological way that we can help with pain management. And the idea behind gate control theory is that the nerve impulses can only sense one impulse at a time. And so if we are stimulating positive chemoreceptors in the brain, then the body's not paying as much attention to the negative. So we are distracting the patient from the pain. And we can do that with things like massage, things like there's chemoreceptors all over the body that are positive. So like rubbing the hands and feet, sometimes like brushing hair, massaging the back, stuff like that can trigger the sensory nerve pathways to pay attention to that and not to notice the pain as much. So that's gate control theory. Other things we can do non-pharmacologically. There are so many things we can do. And this can work, guys, not just for your labor patients. We can use a lot of these ideas for your med-surg patients or any other area of the hospital. We can use these ideas for ourselves. So for in labor, what we're thinking about is there's a few things we think about. So we're thinking about gate control theory. And so massage, heat and cold, acupressure, stuff like that. We're thinking about positions we put mom in. So if her baby is occiput posterior or OP, we're getting maybe more back pain because the bones of the head are on mom's back. And so counter pressure on her sacrum can help. All right, if that's where her pain is. Ambulating to help the baby, help keep things moving, help the baby descend early in labor is a good thing to do. We can think about breathing techniques, aromatherapy, lots and lots and lots of stuff. Water, oftentimes I'll put a naturally laboring mom in the tub. Okay, water therapy helps a lot. Lots of things you can do. And then so many positions you can put moms in for comfort. And remember, maternal position is one of our P's. And so sometimes this can help us get a baby in a better position to fit through the pelvis. And so we think about different positions that are going to create space for our babies to flex and to come down and descend. Okay. Pharmacologic pain management. So in addition to all the non-pharmacological things we can be doing, we often end up considering pharmacological pain management as well. And so for this, we're thinking we need to be mindful of the fact that if we're giving medications do cross through the placenta to the baby. And so I don't want to give mom a narcotic if she's close to delivery, because it can actually depress the baby and cause respiratory depression for the baby. Okay. So this is something that we consider. And we are mindful, like if our baby doesn't look good on the tracing, maybe I can't give her a medication that goes through her IV. And so there's a lot of considerations pharmacologically with pain management. The other thing that we use a lot is going to be our epidurals. Okay, so neuraxial anesthesia. So when we think about anesthesia, there's a few different things. One of them is called a pudendal nerve block. This is where they actually inject numbing medication into the pudendal nerve, and it numbs the perineum. So remember where the perineum is. It's going to help decrease the sensation in that area. And so that is a good last choice for somebody who didn't get an epidural and is really uncomfortable with crowning, and wants something now. Because if we're that close to delivery, we're not giving her IV pain medication, we're not giving her PO pain medication, and I can't give her an epidural now. Okay. But epidurals and spinals, these are our sensory blockades that we use the most. Okay, spinals are typically used for cesareans. Okay, and those are going to be your scheduled cesarean. She came in, she had a cesarean before, she's having a cesarean again. They put in the spinal and do her C-section. If we're doing pain management in labor, we're doing an epidural. And so an epidural is very effective. The medicine does not cross the placenta to the baby. And so that's good. The things it can cause, though, is that it can cause vasodilation for the mom. And so when we get vasodilation in the beginning of an epidural, think about what that might do to her blood pressure. Okay, so here's how this looks. All right, so this is the epidural space. And so we have the spinal cord, and actually the epidural goes below the spinal cord. We have the dura, and inside the dura, this is where cerebrospinal fluid is. And then we have the epidural space. And so this space exists before the dura and before the cerebrospinal fluid. And the idea is to put this into that space. And so they use a needle and they access the space. They put some fluid in it to open it up. And then they put a tiny catheter tube in that space that they can continuously infuse medication into. Now, if this is placed properly, it will not interrupt the dura. Therefore, there's not a risk of a spinal headache. However, it is possible for the needle, as they're placing it, to nick the dura. And so if that happens and cerebrospinal fluid starts to leak, then that's when a patient could get a spinal headache. And we're not seeing a spinal headache on labor and delivery. We're seeing this tomorrow on postpartum. Okay. If that happens, we would fix, one way we can fix a spinal headache is with a blood patch. A blood patch happens when the nurse sterilely draws up blood, hands it off to the anesthesiologist or nurse anesthetist, and they go back into the epidural space. They inject that blood into the space, and it acts as a space holder until the leak stops. Okay, because what causes the spinal headache is if the cerebrospinal fluid is leaking. Now we've changed the pressure in there, and it pulls on the nerves in their head, in their brain. Okay, but most often spinal headaches aren't the big concern. The biggest concern is going to be the hypotension. When we give the medication for an epidural, it causes vasodilation, and now the brain is not seeing the lower part of the body the same because we've interrupted those nerve impulses. And so it doesn't initially reconstrict those vessels to send the blood back up. And so for a little bit, if we have hypotension, we can see how that could affect our baby, because we're not perfusing our placenta as well. Okay, so things we can do for that: we can give a fluid bolus to moms before she even gets an epidural to help support that blood pressure, and sometimes we give medicines if she's hypotensive after the epidural to help reconstrict those vessels. Okay, so Epidurals and spinals are going to not have a lasting effect on baby. They can cause hypotension. Also, she's not feeling her bladder the same, so we need to manage her bladder for her. So we either are straight cath every few hours or putting in a Foley to keep the bladder empty. And then we're assessing her pain. Is it working? Is it doing what we need it to do? The other thing that can be a contraindication for an epidural is going to be if she has a coagulopathy. So women who have like low platelets or thrombocytopenia, they have increased risk and they oftentimes aren't able to get an epidural. So that's a consideration. When I often see thrombocytopenia affecting an epidural is going to be like in your preeclamptic patient or HELLP syndrome. The nurse should realize that the most common and potentially harmful maternal complication of epidural anesthesia would be what? Severe postpartum headache, limited perception of bladder fullness, increase in respiratory rate, or hypotension. And hypotension is the concern, okay? Because that can cause hypoxia for our baby. Other types of things we can consider for pain management, nitrous oxide. Nitrous is something that the patient controls. They hold their mask, they inhale and breathe it in and out of the mask. It decreases their anxiety, it can cause euphoria, and it reduces their pain perception. I also think it really helps them focus their breathing. General anesthesia is something we don't commonly use in OB. There's a time and a place for it. So when we talk about emergencies later this term, there's some emergencies that we need general anesthesia for. But most of the time, pregnant ladies are hard to intubate. And so we don't want to use general anesthesia unless it's an emergency. So it's not common. So now we're going to start thinking about our baby and what affects oxygenation. And we talked about some of this already when we were thinking about how baby is affected by labor. All right. So things that can decrease our oxygenation to our baby. All right. So reducing blood flow through the maternal vessels due to hypertension, hypotension, or hypovolemia. So remember, we've said before, blood pressure affects the way we perfuse the baby. If we have cord compression, anything that presses on the cord is going to decrease the blood flow with the oxygenated blood to baby. Remember which vessel has the oxygenated blood. It is the vein. And the vein is big, and if there's pressure on the cord, we're decreasing. Think about if you start partially crimp a hose, we have less blood flow going through. So anything that's putting pressure on the cord is going to contribute to a decrease in circulation of oxygenated blood to the baby. And then the other thing that can affect this is going to be the contractions. As we have already said today, that whenever the uterus is contracted, there's not blood flow going to the placenta during that time, or it's greatly minimized. And so decreased oxygenated blood coming to baby, if our contractions are too close together, lasting too long, we call that either tachysystole or uterine hypertonus. We have too much tone or we have too many contractions. And so for these, if this is what's happening, then we are decreasing blood flow to baby that way. Okay, supine hypotension, we've talked about that before. If mom has disorders or lifestyle choices that affect her vascular system, I'm thinking about smoking causes chronic vasoconstriction. These are all things that can affect our baby. Okay, how do we listen to our baby and know how our baby's doing? We can use intermittent auscultation where we use a Doppler. This is going to be ideal for somebody who's low risk or in the early part of labor. And this is where we just listen to the heartbeat on a schedule. All right. And then we have fetal monitoring. So we can do internal and external fetal monitoring. And this is how we're going to determine how oxygenated our baby is during labor. If we have abnormal patterns in our fetal fetal heart tracing, then that is associated with hypoxia. And if we have hypoxia, then our baby can become acidotic, and those babies have a risk of developing cerebral palsy. So everything that we're going to be talking about in relation to fetal monitoring is to prevent that. Prevent acidosis for the baby, prevent cerebral palsy, prevent encephalopathy, things like that for the baby. Okay. So if we're doing external monitoring, that's like this first picture here. So when we talk about where we're going to listen for baby, we can do our Leopolds and figure out where the back is and put our monitor on the side where the baby's back is. And if our baby's head is down, then we're putting it down low below the belly button on whichever side. And we're going to listen to the baby's heart. Okay. And then we can do a tocotransducer at the fundus. And that's going to just feel the pressure when her uterus gets tight. And on our tracing, it makes a hill and shows us where the contraction happens. Okay, so that is our external monitoring. Most of the time we're using external monitoring because it's non-invasive, right? If we're going to do internal monitoring is going to require a cervix that has started to open so that we can go put our monitors through the vagina, through the cervix, and into the uterus. The internal monitor to measure contractions is called an IUPC, or an intrauterine pressure catheter. And it goes inside the uterus and it measures in millimeters of mercury the actual strength of contractions. For the baby's heartbeat, the way that we can monitor this is with a fetal scalp electrode. And that's what it is. It goes on the fetal scalp. And so it's placed through the cervix onto the baby's head. And then the little cord comes out and attaches to the mom's leg. And it shows us what the baby's heart rate is and what's happening with the baby. So those are different monitoring systems. So when we look at fetal heart rate patterns, there's a lot that goes into this. All right. Our normal fetal baseline should be, the heart rate should be between 110 and 160. Okay. We are going to look for a few things. We're going to look for what's called variability. Variability on our tracing looks like a squiggly line. So the tracing is kind of like a graph paper. Okay. And the way, what we see on this is going to be, here's different types of variability. So when we look at variability, it's what makes the line look squiggly. And this is the give and take of the sympathetic and the parasympathetic nervous system that's working on this, that's causing this line to squiggle. And so these variations around the baseline is what makes up our variability. And we like these variations to be between 6 and 25 beats around the baseline. So if I say the baseline is 130, my variations will go around the 130 mark. All right. Moderate variability is the best. The other most common one that we'll see is called minimal variability. Minimal variability is less than 5 beats of variation around the baseline. And this can be reassuring. It can also be concerning. So when we think about minimal variability, it might be a baby who's taken a nap. It might be a baby who's becoming acidotic. We don't know. So if we will allow time for a normal sleep cycle, and a baby's sleep cycle typically is 20 to 40 minutes. And if we're continuing to see minimal variability that's extending beyond that, then we need to investigate and see what we need to do to see if there's anything to be concerned about. Other types of variability, not as common. Absent is completely not detectable. It's a straight line. This baby is in trouble. And marked variability is chaotic. These are greater than 25 beats of variation around the baseline. Okay, not super common to see this. The most common ones are going to be minimal and moderate. Okay, so that's variability. The other things we're going to look at is, are we having increases or decreases around the baseline? And this is going to determine if there's anything that's reassuring or non-reassuring about the tracing that we're looking at. We like accelerations. Accelerations is an increase from the baseline. Accelerations need to, if our baby's greater than 32 weeks gestation, then in order to meet criteria for an acceleration, it needs to increase at least 15 beats above the baseline and last for at least 15 seconds. If it's less than that, it doesn't count as an acceleration. I actually saw a provider document last week accelerations 10 by 10, and that doesn't count. Like, that's not reassuring. All right. Now 10 by 10, if our baby's less than 32 weeks, their neurologic system is less developed, and that is acceptable. But in a term baby, it's got to be at least 15 beats and at least 15 seconds. Can be more, but at least that. Okay, so when we count the beats, we're counting up this way, and then we count time across. All right, so that's an acceleration. Our decelerations are going to be when the heart rate changes below the baseline, and different ones mean different things. So an early deceleration, you can see on the bottom part of the graph, you can see where the contractions are. And here is the baby's heartbeat. This baby has minimal variability. And the decrease that happens in the heartbeat from the baseline is mirroring the contraction. So it's starting at the same time that the contraction starts. It hits the nadir at the same time that the contraction hits the peak or the acme, and then it recovers back to the baseline at the same time that the contraction ends. That's an early deceleration. Okay. A late deceleration, with a late, it starts after the contraction starts, and it ends after the contraction ends. These are our most concerning, okay? Because with a late deceleration, this is an indication that we're not getting what's needed to the baby from the placenta. So this would be, maybe I'm seeing this with hypotension after an epidural, less perfusion to baby, okay? And so this happens after. A variable deceleration is not the same as variability. Okay, it just means that the timing of it is variable because it's not related to the contraction. A variable has an abrupt onset, and it is going to also be at least 15 seconds to the nadir, and go down at least 15 beats. So it's similar to our accelerations, 15 and 15 going up, but this is at least 15 or 15 going down, and this is caused by compression on the cord. Okay, so this isn't as dangerous to baby. Over time it can be, but having a variable here and there is not as concerning as the late decelerations. So those are what they look like. So now if we come back to veal chop, this is a great way to remember, if this is what my decel looks like, this is what's happening. All right. So a variable deceleration is that abrupt onset, at least 15 beats and at least 15 seconds. It's caused by cord compression. An early deceleration mirrors the contraction, and it's caused by head compression. Accelerations are okay. Our baby's well oxygenated if we're having accelerations, and those need to be 15 beats by 15 seconds of an increase. And then our late decelerations are late. So the onset happens after the contraction has started. It does not resolve until after the contraction has ended, and this is a placental insufficiency. All right. So if we do veal chop, we write the word veal, we write the word chop, and we look straight across. So here's veal, here's chop, we look straight across. So what do we do? If we're seeing these changes in the heart rate, we need to address it. Okay, so the way that we manage abnormal patterns, we can use a few different mnemonics to try to identify the best way to manage them. Okay, this one over on the left is spoilt. This one is going to most accurately address the things you need to remember. All right. So it's not in order though. So stopping Pitocin, remember if the uterus is contracting hard and fast, that affects our perfusion to our baby. That can cause decelerations. And so if she has Pitocin running, then that is going to be increasing her contractions. So maybe I need to stop it and turn it off. Position change. This is our number one go-to. All right, if I'm having variable decelerations and I change her position, that can relieve the pressure on the cord. If I'm having late decelerations and I change her position, that can increase perfusion to the placenta. So position change is the first thing to do. Okay, oxygen. So oxygen is still on the list of things to try. In practice, we are getting away from using oxygen for treatment of abnormal patterns unless nothing else is working because it doesn't show a long-term benefit to the baby. All right, but it's still on the list. So oxygen, we can do 10 liters on a non-rebreather. IV bolus. So IV bolus is a good thing to consider if the blood pressure is low and we're having a placental perfusion issue. Low blood pressure, treat the cause. So again, if we just did an epidural, maybe I need to manage the blood pressure. Maybe I'm not perfusing the placenta well. And then tocolysis or tocolytics. These are things that help relax the uterine muscle. And so this is medicine that's going to slow those contractions down to give us more time to perfuse the placenta. And the big one we use for this also starts with a T. It's called terbutaline. Side effect though for terbutaline is tachycardia. So I want to know what my mom's vital signs are before I give her this medicine. And I'm going to tell her it's going to feel a little bit like she just had a whole lot of espresso. Okay. And then we're notifying. If we're having decelerations, if we're having prolonged decelerations that are lasting longer than 2 minutes, or we're having late decelerations that we're needing to intervene on, we also should let the doctor know. So this is a chart called veal chop mine. So veal and chop is the same as what we already said, but now we added another acronym to remind us what to do. So if we have variable decelerations, we're reminded that these, like if you think about what words you would see in a question that would mean a variable in your brain. Variables have an abrupt onset because they have that V shape. They're caused by cord compression. So if your question says that you're having deceleration with an abrupt onset, I'm thinking that it's a variable. I have cord compression. And so the first thing to do is to move them up. Relieve the pressure on the cord. Early decelerations, the words that I might see that would remind me that it's early is that it mirrors the contraction or it happens at the same time. And these are caused by head compression. And the I in mine means intervention's not needed, because this is a sign of progress in our labor. If I have early decelerations, I'm not worried about that. It's not affecting the baby's oxygenation. It's just letting us know that the baby's getting compression on the head and labor is probably progressing. Accelerations. Accelerations are okay. Our baby's well oxygenated, so no intervention is needed. And then late decelerations happen after the contraction onset. After is our key word that we might see in a question. This means placental insufficiency. The baby's not getting the oxygen that it needs from the placenta. And so now we need to evaluate. We need to evaluate why, and we can use our SPOILT acronym and stop the Pitocin, change the position, oxygenate, IV fluid, treat the low blood pressure, and use tocolytics. So which fetal heart rate pattern would be a priority? This one decreases after the peak of each contraction. So that's defining a late deceleration. This one, it says it occurs at the acme. So the acme is the top of the contraction. If the fetal heart rate deceleration occurs at the acme, that is not concerning. Okay, because this first one is happening after, so that's after is late. Okay, during is on time, it's early. An increase in the fetal heart rate to 180 that quickly returns to baseline. That's okay. That's an acceleration. And then a fetal heart rate decel that abruptly drops to 20 beats, lasts for 15 seconds, returns to the baseline with moderate variability. That defines a variable deceleration. So on these, the ones that the one is a priority is A, because that is a late deceleration. So when we look at our contractions, we are counting a few things. We're looking at how far apart they are. So we can count from the beginning of one to the beginning of the next. And usually our frequency is about every 2 to 5 minutes. We're also going to count how long they're lasting, because remember, every time the uterus is contracted, it's affecting our blood flow through to the placenta. And so I don't want a duration longer than 90 seconds. That's too long and it can interfere with the baby's oxygenation, right? I also really want there to be at least 1 minute between when one ends and the next one starts, because this is the time when the baby can get good oxygenation before the uterus is contracting again. So those are the things we're looking for our contractions. If we have an IUPC in place, that's the intrauterine pressure catheter, then we're actually quantifying the strength of our contractions using Montevideo units. And Montevideo units is measuring the millimeters of mercury or the strength of each contraction over a 10-minute period. Okay. So if I have more than 5 contractions in 10 minutes, if I have any contractions lasting longer than 2 minutes, if I have contractions occurring within a minute of each other, these are all signs that our contractions are too close and lasting too long. We call that uterine tachysystole. Tachy is fast and systole is contraction. Okay, and so for that, now I need to try to slow that down. So if she's on Pitocin, I would be turning it off. So it just would be dependent on what the circumstance was, but remembering that all of those things are going to have the potential to cause hypoxia for the baby. True labor versus false labor. So we learned that the uterus can contract and not make change to the cervix, like not cause it to dilate. So when a patient's having contractions, how do we know she's in labor? The definition of labor is contractions that produce cervical change. So we need to see if she's changing her cervix. Okay. Typically, contractions that are going to change the cervix are increasing in frequency, they're increasing in intensity. And if she's walking and doing activities, they're getting stronger, they're getting closer together. She often feels them in her lower back, they radiate to the front, and now the cervix is making change. With false labor, these contractions might be irregular, they might space out or go away when she's walking and doing activities. Oftentimes she feels it higher on her belly, the cervix isn't changing, it improves. With activity, with position change, with rest, with hydration, it gets better. And so if she is not having true labor, she can probably go home. All right. As long as we have a reassuring fetal heart tracing, if her cervix is not making change, then oftentimes those moms are sent home. Assessments in labor. So things we're assessing, in addition to all the stuff we've talked about for prenatal, we still want, again, to make sure we know a lot of those same things. I want to know, what I really want to know is things like, where is she in her pregnancy? What's her gestational age? Because that's going to affect how I take care of her. Okay. I want to know things like her RH, and things like that. I want to know if she has STIs. I want to know those things. But the things I really want to know is what position's her baby in. If she thinks she's in labor, I want to know if the baby's head down, what the gestational age is, if the water bag is broken and what color the fluid is, how often she's contracting, and I especially want to know how's the baby. So a patient comes in, one of the first things I'm going to do is put her on the monitor and start tracing. I can ask a lot of those questions that we have asked before with our patients, things like their health history, their their obstetric history, allergies, things like that. Okay. As far as membranes go, if she thinks her water's broken, we can test that with pH paper. And so amniotic fluid is alkaline, and so it turns pH paper like a dark blue. And if her water's not broken, oftentimes vaginal secretions and discharge are more acidic, so then it looks more yellow. So if the water is broken, the water should be clear. Okay, we might see little flecks of white in it. That is vernix. That's normal. If there's green stain in the fluid, the baby might have passed meconium. And then I worry that the baby could have what's called meconium aspiration syndrome, where the baby breathes that in. Okay, and so that can affect the baby and cause respiratory difficulties and pneumonia for the baby after they're born. I want to know if the fluid has an odor. If it has an odor, that can be a sign of infection. I want to know how much fluid came out, how much is still coming out, and we're going to keep track of what time the water broke. Okay. For however many hours after the time the water broke, the longer we are away from that, the higher incidence of infection, developing chorioamnionitis. Okay. And I want to monitor the baby after the water breaks, because if the umbilical cord slips down in front of the head, then it can cause cord prolapse. That is an emergency. And also true that once the water breaks, it's changing the way pressure happens on the cord with contractions. And so I might see variable decelerations, different things. So I want to watch and assess the baby after the water breaks. A client admitted to the birthing suite in active labor, the priority nursing intervention would be to oscillate the fetal heart, take obstetric history, ask the client when she last ate, or ascertain whether the water's broken. And my very first thing is love baby. Assess the fetal heart rate, letter A. Second stage of labor. So remember, guys, second stage is when? Second stage is from when we're completely dilated to the delivery of the baby. And so this is where we bring the power, our pushing efforts. Okay, this can take a long time. For a first-time mom, she can push 3 or 4 hours, truly. Okay, we can encourage a lot of position changes during this time, especially pushing in a more upright position. Even if she has an epidural, I can put a birthing bar on the bed and get her more upright and let gravity help move that baby down. We can kind of have her squat with the birth bar. Women that are unblocked, don't have an epidural, they can stand. They can push in a lot of different positions. Okay. As the nurse, we're doing a lot during this time. So in addition to helping her know when to push, we're kind of coaching that pushing effort. And so we would like to encourage what we call open glottis pushing, where it's like short grunty pushes, because when they do the hold your breath and count to 10 thing, that's called closed glottis pushing, and it decreases cardiac output and it decreases perfusion to the baby, and it can cause hypoxia over time. So open glottis pushing, short, like until they need a breath, kind of, okay. And we're changing her position. We might be doing warm compresses, cool compresses, adjusting the environment, keeping the lights dim, adjusting the temperature, helping her relax, keeping her calm, and taking care of the partner who is also needing all of that. We're getting our supplies and equipment ready because we will be calling our provider for delivery. when the baby is close to birth. And so the birth of the baby is the end of second stage. Immediately after the baby comes out, we have that second nurse there, and she's the person, she or he is the person that is managing the baby. And so we immediately put that baby skin to skin with mom. We can delay the clamping of the cord so that the placenta can continue to give oxygenated blood to the baby. And the nurse that's taking care of the baby is doing the baby's vital signs and assigning APGAR scores. We are going to learn a lot more about APGAR scores with newborn, but this is how our APGAR scoring system works. And these are two different pictures of the same thing. Okay, so we assess every baby at 1 minute of life and at 5 minutes of life. And what we're looking for is, how's the color? Are they moving? How are they breathing? How's the heartbeat? Okay, and so if they're doing what they're supposed to in each category, they get 2 points. If they're not doing it, they get 0 points. And if they're doing it a little bit, they get 1 point. And so we would like an APGAR score of 7 or better. Every baby gets assessed at 1 minute of life and again at 5 minutes of life. If at 5 minutes of life we have an APGAR score of 7 or better, we don't continue to score it. This is what the umbilical cord looks like. So which one do you think has the oxygenated blood? Which one is the vein? This big guy here is the vein. So this is where the oxygenated blood is. If I take blood from here and I send it to the lab, it's going to give us a really good idea of what was coming into baby. What I care more about was what was coming out. Is the baby acidotic? What's going on with baby? So what is coming out of the artery is more important. So in this picture, you can really only see one artery. Remember, there's two, but they're smaller and they're harder to get blood from. Okay, so we can do cord blood gases. We'll send a sample of both the artery and the vein for compare to see what the acid-base balance is, and especially if our APGAR is 5 or less. Third stage of labor is that delivery of the placenta. We're expectantly and actively managing this, all right, because we don't want a hemorrhage. But again, this can take up to 30 minutes. The nurse is also going to send cord blood to the lab, and that's how we're going to find out what the baby's RH status is. Because remember, if mom is negative, I want to know if baby's positive. That's going to affect if mom needs RhoGAM. After the placenta delivers, we give oxytocin to help the uterus contract and squeeze and tamponade the vessels that we're feeding it so she doesn't bleed too much. And we can also start massaging the fundus. The fourth stage of labor is the first 2 hours after delivery. So now we're watching her vital signs. We're assessing the fundus to make sure it's firm. We're watching the bleeding to make sure it's normal. We continue to manage the bladder. And then this is also when we're breastfeeding and getting baby latched. So nurses examining a woman an hour after birth, and the woman's fundus is boggy midline and a centimeter below the umbilicus. Her lochial flow is profuse with 2 plum-sized clots. The nurse's initial action would be to what? Put on a bedpan to empty the bladder, massage the fundus, call the doctor, or administer Methergin. So the fundus is not firm, it's boggy, and she has profuse flow. The very first thing she should do is massage the fundus. I need the doctor. I probably need to give Methergin to help the uterus contract, but I need the doctor in order to have orders to give this. But the very first thing I'm going to do is massage the fundus. I got to get that muscle to squeeze. And that is the end of labor and birth.